Good evening everyone. What I will be talking in next 18 minutes or so, the importance of postprandial hyperglycemia in trying to achieve the difficult goal of HbA1c target of less than 7. We all know that early defect in type 2 diabetes is the postprandial hyperglycemia. Usually if you see the impaired glucose tolerance data, the postprandial hyperglycemia or post-glucose hyperglycemia precedes by 4 to 7 years before fasting hyperglycemia becomes evident. And the first phase insulin response is the first beta cell dysfunction in type 2 diabetic patients, which may start 4 to 5 years before the onset of diabetes or the diabetes is detected. And we all know that most of our diabetic patients spends more than 12 hours of their time in postprandial state, mainly because of the drugs or insulin which we give to avoid the hypoglycemia. We ask the patient to have the small frequent meals. So hardly 8 to 10 hours in the day we are in the fasting state, right? Most of the time we are in the postprandial state. So if you see the diabetics prevalence in India is significantly increasing, and one of the reason is the Indian diet is not only high in carbohydrate. Gradually we have converted our carbohydrate rich meal from the polished to the polished cereals, refined cereals and carbohydrates. And in the study called STAR study, the pan-India, if you can see, around 65% of our calories are coming from the carbohydrates, whether patient is from north, south, east, west or the middle of the country. And 62% of the diabetic populations during this study had a target postprandial of 180 not achieved. So they were uncontrolled postprandially. And higher the carbohydrate intake in the diet directly related to the higher postprandial blood sugar values. You can see here, if you distribute the carbohydrate load over the meals, there is a lesser rise of the postprandial hyperglycemia. As soon as you load with any meal, the carbohydrate rich meal, the postprandial surge significantly increases. And we load with the breakfast time, lunch time or the dinner time. And unfortunately, we don't just have the high carbohydrate intake, but our guts or our body probably handles the carbohydrate in a different way compared to Caucasian populations. And you can see here the same diet, 5 different carbohydrate rich diet were given to the Caucasians versus Asian Indians, and you can see the glycemic response to the Asian Indians, the similar carbohydrate rich meal was quite different compared to Caucasian population. So we have dual problem of high carbohydrate intake, and second problem is our guts probably or the body. Here in another study, the 75 gram of bread meal was given, Indians versus Caucasians, and you can see that we respond to the same amount of carbohydrate in a different way compared to Caucasians, ultimately leading to the hyperglycemia and increase in the insulin resistance. And we all know that we all would wish that our patient achieves the target of A1C of less than 7%, and there is a very well known fact that up to 8.5% of the A1C gets contributed predominantly by the postprandial blood sugar, but as the A1C goes above 8.5, there is more contribution of the fasting. But Indians, again here the scenario is different. You can see here Asian Indian populations compared to Western populations. You can see even up to the A1C of 12, 50% of the contribution to A1C is coming from the postprandial state. Compare that to the Western population, where almost 70% is coming from the fasting hyperglycemia. So we have to take care of the postprandial hyperglycemia irrespective of the HbA1c level. And you can see here the Indian versus Caucasian data. You can see here the A1C of 9.8, 9.6 compared to Caucasians. We have significant postprandial hyperglycemia. You can see here 287 versus 270 versus 380, 220 versus 280. So irrespective of the A1C, even at the higher A1C, postprandial contributes significantly to the A1C in our populations. Even at the fasting plasma glucose of less than 125, we all say that you start your day with a good fasting plasma glucose, then you would probably have a better postprandial control. But in spite of achieving a good fasting hyperglycemia, fasting sugar less than 125, almost half the patients still have a postprandial blood sugar which is quite above the target, that is about 200. So if you see the data, 80 to 85% of the type 2 diabetic patients has more than 160 blood sugars at postprandial level recorded at least once during the monitoring. Postprandial hyperglycemia is almost present in 60% of the newly diagnosed type 2 diabetic patients. And if you collect the data of fasting, those patients who have fasting plasma glucose of less than 100 achieved, only 64% of the patient could achieve the A1C target of less than 7%, even though the fasting is very well controlled. But if you take the data of postprandial blood sugar of less than 140, almost 95% of the patient could have A1C target of less than 7% achieved. So if you could achieve the good postprandial hyperglycemia, there is good chance that you would be able to reduce the HbA1c significantly. And it is not just the postprandial hyperglycemia which is a problem, but we all know that there is a lots of postprandial hypertriglyceridemia, increase in the fatty acids and the oxidative stress. All this together probably leads to the higher cardiovascular risk also. So we have a higher glucose load and we got a higher glucose curve, and it ultimately leads to the link to the increase in the cardiovascular diseases. So even the IDF guideline says that postprandial blood sugar target should be less than 160 mg should be achieved, provided you don't develop too much of hypoglycemia. And if you see the Indian data, 1/3 patient could have a target of A1C achieved, that is less than 7%, 7 to 9%. A1C was seen in another 1/3 patient, and 1/3 patient has A1C level was more than 9%. So hardly 1/3% of the patients have good HbA1c control. So whether this postprandial hyperglycemia is harmful or not, what are the evidence? Postprandial hyperglycemia is directly linked with the macrovascular diseases with level of evidence 1+. It is associated with increased risk of retinopathy, increased risk of cancer, impaired cognitive dysfunctions in elderly patients with type 2 diabetes, increase in the carotid intima media thickness, decreased myocardial blood volume and myocardial blood flow, increase in the oxidative stress, endothelial dysfunctions and the inflammatory markers. Altogether, IDF says that postprandial hyperglycemia is definitely harmful and should be addressed. So why actually postprandial hyperglycemia is harmful? Because of the vasculotoxic consequences of the postprandial hyperglycemia. Because postprandial hyperglycemia is not just the hyperglycemia, it is the dysmetabolism state which occurs in the postprandial state if the postprandial hyperglycemia is not controlled. There is endothelial dysfunction, increased glycations of the functional proteins, increase in the inflammatory cytokines, increased expression of the adhesion molecules and generations of the free radicals get affected. Altogether, there is a vascular damage with generation of the atherosclerotic plaques. So what are the data whether postprandial hyperglycemia is harmful or not? If you see the predictor for early mortality for type 2 diabetic patients and see the different risk factors ranging from BMI, smoking, systolic blood hypertension, diastolic hypertension, fasting hyperglycemia and postprandial hyperglycemia. Postprandial blood sugar of more than 200 has the highest odds ratio of increase in the early mortality for type 2 diabetic patients. So it is definitely a significant risk factor, and the landmark DECODE study very elegantly showed that they compared the fasting and postprandial blood sugar, and you can see fasting going from less than 100 to 111 to 125 and then above 126 with the same amount of fasting hyperglycemia. Slight increase in the postprandial blood sugar, say from less than 140 to 141 to 200 and more than 200. The hazard ratio almost doubles with 40 to 60 mg increase in the postprandial state, though the fasting blood sugar is the same. So postprandial hyperglycemia clearly predicted all-cause mortality in this DECODE study. In another Honolulu heart study also, the postprandial hyperglycemia, specifically above 160, has clear correlation with fatal coronary artery diseases and total CSD mortality. Diabetes intervention study also showed post-meal plasma glucose, but not fasting plasma glucose was an independent risk factor for myocardial infarctions and the mortality. And DECODE Asian study also showed 2-hour post glucose challenge was directly linked of premature death and the CVD in the diabetic population. And there are lots of studies having strong binding between the PPBG and the cardiovascular events. So IDF guidelines says that postprandial hyperglycemia is bad and needs to be addressed. So what does the options available with us? There are several classes of pharmacological agents which preferentially lower the post-meal plasma glucose with level of evidence 1+. This includes AGIs, glinides, short-acting sulfonylureas, insulin short-actings, regular or the analogs, GLP-1 agonist and the DPP-4 inhibitors. If you see the commonly used drugs for postprandial hyperglycemia reduction, the glinides reduces the postprandial hyperglycemia. The problem is the hypoglycemia and some amount of weight gain. AGIs reduces the postprandial hyperglycemia, but it is problem of the GI disturbances and it is contraindicated in patients of the inflammatory bowel diseases. DPP-4 inhibitors significantly reduces the postprandial hyperglycemia. And rapid acting insulins are injectable, requires dose adjustment. So glinides the risk of hypoglycemia and weight gain. DPP-4 inhibitor high cost of therapy, and there is some question mark about the patients having existing LV dysfunctions, whether we should be using safely or not. Insulin is good potent drug to reduce the postprandial hyperglycemia, but requires dose adjustment, risk of hypoglycemia and weight gain. While AGI is effective in Indian settings due to high carbohydrate centric Indian diet pattern, it is usually safe and well tolerated, except initially some of the patient may have some GI disturbances. No risk of hypoglycemia, no risk of weight gain, and it has proven cardiovascular safety, and there are definite data that it is to a certain extent cardioprotective also, and that is why IDF algorithms with type 2 diabetics now advocates AGIs as a first line, second line and third line or as add-on therapy in trying to achieve the hyperglycemia. So what is the relevance of AGIs for patients who are uncontrolled on metformin? Indian diet is rich in carbohydrate. Compared to Western world, postprandial hyperglycemia is higher among our populations. Carbohydrate load determines the postprandial rise in the blood sugar. So either we have to go for the diet modifications or we have to give the agents which slows the absorption of the carbohydrate and to take care of the postprandial control in a comprehensive way. And if you take care of the postprandial hyperglycemia, we don't just achieve the glycosylated hemoglobin target, but we decrease this metabolism state and atherosclerotic process occurring with the postprandial hyperglycemia. And this group of the drugs are the drugs which are independent of insulin. So here you can see Cochrane meta-analysis, acarbose compared to placebo. There is a significant reduction in the post-load blood glucose values, but this could be achieved with less amount of insulin secreted in the body. So it is a insulin sparing or beta cell sparing mechanism which is there. But if you see the body weight gain and the hypoglycemia, there is no body weight gain and there is no risk of hypoglycemia, and this can be achieved reasonable good glycosylated hemoglobin control without producing hypoglycemia in the weight gain. And many people would argue that postprandial hyperglycemia is not that significantly controlled with the AGIs. But if you see the data of around 14,000 patients, higher the baseline postprandial blood sugar, more significant reduction with the AGIs can be seen to the tune of around 200 milligram if the baseline postprandial blood sugar is high, and that is true for all the drugs actually. The higher the glycemia to start with, more response is to that particular drug. And it not just decreases the blood sugar value postprandially, it decreases the glucose fluctuations which occurs in postprandial state. Here the patient was on basal insulin with insulin analogs, and this is the patient on basal insulin with AGIs, and you can see there is less surge of the blood sugar without going in the hypoglycemic range. So glucose variability also is reduced with AGIs. Here also you can see voglibose compared to sulfonylurea. There is a significant reduction in the postprandial state, and there is a less glucose variability postprandially with the voglibose compared to sulfonylurea. Whether it gives the long-term glycemic control or not, this is a 5-year data with the acarbose, and you can see that because it acts independent of the insulin, so whether beta cell is failing or not, it is going to work. So you can see that up to 5 years there are data that AGIs can have a sustained glycemic effects, and this is a 5-year data with a different combination with reduction in the glycosylated hemoglobin and the body weight, and it showed that it does it significantly up to 5 years. And if you compare AGIs with the gliptins, these are 24-week studies where comparable reduction of acarbose compared to vildagliptin, and significant A1C reduction, and with some weight loss was there with the AGIs. AGIs stimulates the GLP-1 also, because the unabsorbed complex carbohydrate in the distal part of the intestines would stimulate some GLP-1 secretions, and this is the data of the control versus the patient given the acarbose, and this is the GLP-1 levels, and you can see there is a significant increase in the GLP-1 level postprandially if patients are given AGIs. So what are the cardiovascular benefits with the AGIs? In the STOP NIDDM study, clinical myocardial infarction, any cardiovascular event, new hypertension, all significantly reduced, though the number of events were small, so it looks more like 90%, but the number of events were small because it was not predominantly a cardiovascular driven study, and it was a IGT patient, so it was not a high risk population, so number of events were less, but it clearly showed that there is some cardiovascular protection. In the MIRIA study, the meta-analysis on the type 2 diabetic patients, clinical myocardial infarction and any cardiovascular events were significantly reduced if the patient was on acarbose. You can see here cardiovascular deaths were reduced by 40%, infarction by 70%, angina by 33%, and any cardiovascular events was reduced by 44% if the patient was on AGIs. Acarbose treatment increased the probability of remaining free of any cardiovascular event up to 5 years. The patients on placebo versus acarbose, the cardiovascular events were significantly less for 5 years. The patient group was containing the AGIs. Among the AGIs, the main side effect is the GI side effect, predominantly flatulence, abdominal heaviness, and occasionally diarrhea. And among the 3 AGIs, voglibose has the least GI disturbances. The key of AGI is to start with a small dose and gradually step up the dose, so body get used to the unabsorbed carbohydrate in the distal intestines, and there is less GI side effects. So summarizing, PPG is an independent risk factor for both morbidity as well as mortality. PPG is a better predictor of all-cause mortality and the cardiovascular deaths than fasting hyperglycemia. Postprandial hyperglycemia may have a direct toxic effect on the vascular endothelium. Better control of postprandial hyperglycemia directly contributes to better A1C control and the cardiovascular mortality reduction. PPG is found to be elevated irrespective of A1C levels, at least in Indian populations. So we have to target the postprandial hyperglycemia irrespective of the A1C levels. Control of PPG is more important along with the fasting hyperglycemia control in achieving the A1C. AGIs are recommended first, second and third line agents in this management of type 2 diabetic patient when A1C is not under target. AGIs are proven to increase the GLP-1 levels, which augments the postprandial control indirectly. So judicial use of these agents in combination may significantly decrease cardiovascular risk in patients with type 2 diabetic. And at the last, all of you are cordially invited to ASICON 2015, that is the annual conference of Endocrine Society of India, which we are going to organize at Ahmedabad from 18th to 20th of December 2015. Thank you very much for your patience here.